Well, good evening, everybody. I want to welcome you and to our first in a series of 3 town hall webinars on creating a framework for anti-racist drug policy. I'm Joe Turner, co-chair of the New York State Harm Reduction Association, along with Alexis Plus. And want you to know that the association is a membership collective of well over 25 harm reduction agencies throughout New York State. And basic purpose is to promote harm reduction as a scientifically based approach to substance abuse disorder, as well as a lifestyle approach for people who use drugs. Many of our agencies have been in the struggle for the last 30 years, before harm reduction was called harm reduction. And we met and decided that we're stronger together than we are alone. And that we want to leverage this strength to reduce the harm that not only problematic drug use inflicts on the individual, but also the harm that society inflicts on people who use drugs and the rest of us. Namely through barriers to healthcare, namely structural racism, namely stigma, language, inadequate healthcare, that racism is indeed alive and well. It hasn't gone away. It's still with us. It's racism, not racewism. So we're glad to be here with a distinguished panelists, folks I know who have a body of work in this field that is without parallel. Tonight we're going to focus on the history of racism embedded in drug treatment and the war on drugs. And we're here to have with us, and they'll do a much better of explaining their walk in this journey than I will, but we're so glad to have with us Dr. Sam Roberts. Dr. Roberts is with the Columbia School of Public Health. He's an associate professor of history, of socio-medical sciences, and an author. And he is an historian that's in his DNA. We're also glad to have with us Sheila Vakharia, who's the Deputy Director of Research and Academic Engagement at the Drug Policy Alliance, and also Dr. Helena Hansen, who is an Associate Professor at the Department of Psychiatry at NYU. And each again, their bios were posted on the announcement. As we say, the word speaks for itself. So we can begin this town hall with a question that I'd like to pose to each of the panelists. And that is simply, can you tell us about your work related to the history of racism and treatment and the drug war? And I guess we can start with Sam, Helena, Sheila, or whoever's first. Go right ahead.
I think I was supposed to, was I listed first on the program, Joe? I don't want to speak out of turn, but which,
yes,
is that right?
Did.
Yeah, okay, all right,
you're
great,
strong
thank
on
you.
Me, right.
Thank you so much for the invitation. Joe, you know I've been a fan of you and your work for many a year. Alexis, thank you so much for your role in putting this together and the work that you all continue to do for our city and for our state and really for the whole country at this moment. It's a really weird time. And it's really also one that we're called to rethink a lot of our assumptions, which I think has been happening for a while in the anti-mass incarceration movements, certainly in the anti-drug war movements, in the harm reduction movements. And of course, a lot of those come together in this umbrella phenomenon that we've been calling Black Lives Matter. Certainly this is all part of that. And now it seems like 2020 is the year where we have to rethink a lot of things, not just policing, but I would probably say the top, 5 or 6 items, the way that we organize our society. So I've really been looking forward to this conversation in that regard. In terms of my own work, I've come to view the war on drugs very similarly to some of our predecessors in the African American and Latinx harm reduction tradition, which is, and also within the historical tradition, as Joe said, I am a historian. I'm not going to say it's in my DNA, as he claimed. There's a lot of my DNA. I wish I had more historian in there. It might make my job a little easier. But I am a historian, and so I also pay a certain amount of attention to the longer intellectual tradition of critical thought, particularly in African American political and intellectual theory and organizing action. So in that regard, I see the war on drugs as being, I don't think it's really that controversial in any audience, let alone the one that we have assembled on this evening, to say that it's really been more about racial management than it has been about preventing or fighting crime, and certainly not about good public health or good medicine. I think the historical evidence in support of this is pretty well known. I think accepting perhaps the current moral panic around opioids and our discovery that white people can also have issues with drugs as well. I would say every moral panic we've had around drugs in this country has been tied to the larger and really underlying moral panic around race and racial management, and largely with either immigration or the migration of African Americans to the North, or the desire of newly freed African Americans in the South to pursue their own self-determination. And there in that latter instance, I'm thinking, of course, of the late 19th and early 20th century moral panic around cocaine. But that goes to marijuana and Mexican Americans in the 1930s, smoking opium in the 1870s and Chinese moving forward. Of course, cocaine again in the 80s, crack cocaine, heroin in the 1950s to the 70s. It goes on. And we've made the same mistakes, I think, over and over again. What I think is different at this moment, particularly if we frame this within the movement for Black Lives, is that for some 20, really 30 years or so, we've had the benefit of activists, African American, people of color, Black and Latinx activists, particularly in harm reduction, who have set forward a path for how we should do policy and politics moving forward. That's to say that if our drug policy to this moment has been one of racial management, then certainly just as an exercise of full democratic participation, we need to really pay attention to those people whose communities have borne the brunt of that, and not just for that, but also those people who have done the work in these communities. So that's really where my work lies as a historian, thinking about those histories that often people would rather us bury. I think, when you think of a lot of critiques of the war on drugs, quite often you don't see Black scholars actually or Black activists being discussed there or being cited. You often think of these when people discuss these issues, particularly in mainstream reform contexts, as these are communities which are victims, and certainly they have been victimized. But I would argue that they are more than victims. That if you look at the tradition of political critique since the 1960s, and certainly since the advent of the modern war on drugs with Reaganomics or the Reagan administration in the 1980s, you will find a through line of Black critique, which is very much in line with the critique that we've seen for the longer 20th century. If you look at somebody like Amani Woods, who was shown in one of your slides earlier, she's published a couple of articles, or had before she passed away, in which she was very careful to place her work in the line of Du Bois. She cites, she talks about, organizing as being a continuation of the work of Malcolm X. She also takes from the theory of Frantz Fanon. She's clearly a very sophisticated harm reductionist in ways that I don't think we would see then, or even, to be honest with you, now in mainstream harm reduction. That combination of a Black radical tradition and modern harm reduction tactics is something very unique. And Amani Woods knew that, as did, I saw you had a slide from Deborah Peterson Small, who for, I don't know how many years, at least, 20, a quarter century, has been a leader in this movement as well and has set forward the way. So I think just to end my introductory comments, I think now is a time where we have to really think about how we, to kind of turn the old Marxist phrase, seizing the mode of production or the means of production, we need to seize the means of treatment and the means of harm reduction. It really falls upon those who have done this work to not just dismantle white supremacy and whiteness itself, but it's time now to learn, for us to pay attention to those who have done this work, to find out what is the vision of doing the work. How do we move forward? Not simply about, dismantling, but also how we rebuild. So I would leave there. And I have some other comments to add to that, but I've been really looking forward to the discussion. So I'll stop there. And thank you again, Alexis, Joe, and everyone in the audience for joining us this evening.
Thank you, Sam. Sheila?
Hi, everyone. Thank you so much for joining us today. It's wonderful to see all of these new names in the attendee list and names of friends as well. So my name is Sheila Vakharia. I'm the Deputy Director of the Department of Research and Academic Engagement at the Drug Policy Alliance, which is one of the leading national advocacy organizations here in the U.S., working to end the war on drugs and the criminalization of people who use drugs, and to reduce the harms of these policies and to uplift communities of color who have been disproportionately impacted by them. And I wanted to actually use my intro to actually talk a little bit about myself and how I came to this work. So I studied social work in graduate school, and I was one of those people who always knew that I wanted to be a helper and a healer. And I wanted to help people on their journeys towards health and wellness. And I really hadn't had much of a commitment to what you'd call like a population or a subgroup that I wanted to work with. And it was through, my internship placement that I ended up working at an outpatient drug and alcohol addiction treatment facility. And I was 23 years old, had no personal experience of addiction in my own life or in that of my family. And so I was really socialized into addiction treatment and traditional addiction treatment as we know it as a result of my internship experience at this outpatient treatment facility. And, the vast majority of our clients who were receiving care at this outpatient clinic were people who were mandated to treatment. They were either part of the drug court, they were mandated to care through probation or parole as a condition of their release. There were folks who had active child welfare cases that were contingent upon them completing treatment. And there were a lot of folks whose social services and general benefits were contingent upon completing treatment. So I became the intake counselor pretty soon after getting my internship there. And I did intake assessments all day, in which I was basically taught that I couldn't believe what my clients were telling me on face value during these intake assessments. And what I needed to do was a lot of investigating. And so I spent a lot of time following up on the referral sources, who are often their POs, their child welfare caseworkers, social workers like myself, and other folks who, were helping me put together a puzzle, because I was told that I couldn't trust what my clients were telling me, and that a lot of them were motivated to be in treatment, not because they wanted to be there, but because they needed externalities to be able to get help. And that sometimes people need to be forced into doing what's good for them and what's right for them. And, I spent a couple of years at this treatment facility working very closely and, being steeped in this philosophy of helping and care that really, was grounded in the 12-step fellowship. And I saw the ways that 12-step fellowship and attendance could be really, really helpful for a lot of my clients. But I also saw that eventually, the longer I was there, I became an aftercare counselor, and very few of the folks that I saw at intake ever made it to aftercare. And what often happened along the way was that a positive drug test would mean that I'd have to report to someone's PO, and that would mean that they'd get violated. Or someone would miss a group, and I'd have to tell their child welfare worker, and that would be a demerit kind of on their case. Or I'd have to go to drug court and say that someone wasn't participating as actively as they could, and the drug court judge would take that into consideration and think that sometimes that meant that someone needed to spend a weekend behind bars to get serious and come back to treatment the next week with their head on straight. And after doing this for a little while, I really started to struggle with what I thought helping was and how I thought I was really helping folks. But I still didn't have like a broader analysis on the history of the drug war and why drugs were criminalized and why all these systems were entrenched with treatment and why it was any of their business what sort of help we were providing folks, but also in what ways was my job contingent upon these referral sources continuing to feed in clients to my agency for it to stay open. And I really started to grapple with a lot of this as a young clinician and, decided to make some changes. And I discovered that I really loved working with people who use drugs, but I really struggled with how we were treating them. And so I, chose a job doing a complete 180 and got a job at a needle exchange program and got plugged into harm reduction. And I thought to myself, what would treatment look like if I worked with people who use drugs, who had no one watching over them when they came to get care, and they were coming because they were there on their own terms? And what would treatment look like if I didn't have to tell on them all the time? And what would treatment look like if it could be about our goals and what worked for them? And that was kind of my beginning with becoming a harm reductionist. And after doing that for a few years, I did ultimately decide I wanted to change career paths to get my PhD and, to become a professor and to teach future social workers on how to work with people who use drugs. And it was through my PhD program that I actually started learning a bit about the drug war and drug policy and how it was that drugs became criminalized in this country and that they weren't always that way. And Sam alluded to some of this history, and I'm sure that Helena is going to talk a bit more about it. But I started to really, put some pieces together. And even this idea that I had come to have that addiction was a disease was something that I didn't realize had been socially constructed and had evolved over the years, influenced by mutual aid and self-help groups long before the AA groups that we know of, but that had also this concept of the disease of addiction had also, morphed into a medical disease, and that, we're living during a time where we're both being fed, a spiritual disease model of addiction, a medical disease model of addiction, and then we're still moralizing addiction as, as a crime. And so I, all of that kind of eventually brought me to my work here at the Drug Policy Alliance and thinking about policy reform and really what all of it meant. But I was definitely one of those people growing up who said, I want to be a clinician and I want to help people. And I saw clinical work as the form of help that I wanted to provide. And I really didn't have a broader analysis until after I had left. And I hope that today's panel is an opportunity for folks who maybe are on a similar path that I've been on, to learn a little bit more about some broader context and to put some pieces together that maybe they hadn't considered.
Thank you. Thanks so much, Sheila. Helena? Thank you.
Thank you. So actually my beginnings also lie in activism. And I was reminded as Sam Roberts was talking about the inspiration that he takes from the activists in the current moment, that I came of age during the peak of AIDS activism, just as I had lost at least 2 of my family members to the drug war at the time. And it's really the vigor of AIDS activism at the time, particularly among Black and Brown communities in the greater New York area. I was working in New Jersey, the cities of New Jersey, just fresh out of college as a part of that movement, that I was inspired to become a physician and an anthropologist. And I wanted to carry what I thought were some insights about the power of community into the heart of what I saw at that point as the enemy, the power structure of biomedicine. And that's a project that continues today. So I'm now an addiction psychiatrist and a cultural anthropologist at NYU, where for almost 2 decades, I've been tracking the story of how the current opioid crisis came to be white, or at least came to be seen as white. And I've actually taken kind of the opposite tack from community research that was my origin, in that I have been applying the tools of ethnography, that is observation, interviews, and studying documents to put pharma executives, policymakers, addiction scientists, and prescribers into view in order to unravel the story of how the opioid crisis became quote unquote white. And what I've come up with is a story of white racial capitalism and the ways that structural racism is perpetuated with multiple levels of institutions and policy working in concert as what I call technologies of whiteness. And I can get into more detail about that in our discussion, but it has to do with implicit white racial coding in addiction neuroscience, pharmaceutical development, drug regulation, media, and marketing. And what I've ended up arguing is that in this moment, the perceived whiteness of our opioid crisis has made invisible the ways that the crisis is produced by this structural racism, a form that's actually grounded in white racial coding and which kills both white and non-white people. So it's structural racism based on images of a white clientele as trustworthy. That is the idea that white people are less prone to addiction, to get around regulations, that is corporate strategies to get around regulations of claims to safety and to target marketing. And it's made invisible, this perception of opioid crisis as white. It's made invisible that Black men currently have the fastest rising rate of lethal overdose, something I'm sure everyone on this call is aware of. And then buprenorphine, which is now being held up as our major weapon against the opioid overdose problem. So buprenorphine as a supposed public health measure is largely limited to white people who are 3 to 4 times as likely to be offered buprenorphine at this point as Black people. So, one thing that I think I'm gonna be contributing tonight is a focus on how whiteness.
New York City.
So whiteness, as we speak about racial inequalities, and in my field of biomedicine, we talk about disparities and underserved, quote unquote, minorities in kind of a passive manner. We have to bring whiteness into view to understand that and understand how it's central to our commodified biotech and healthcare industries, their use of racial hierarchies to segment and open markets, and how drugs and race interact with each other. There's a mutual racialization of drugs and people. So Sam mentioned illegal drugs in the US, long symbolically linked to Black and brown people to advance prohibitionist agendas. But one thing we don't often talk about in terms of historical precedent is that drugs can also be white, targeted to white people. This has been going on for a long time, probably starting with heroin itself in the 19th century as it was marketed to middle-class white housewives as a treatment for morphine addiction. But more recently, after World War II, marketing of barbiturates, benzodiazepines, and diet pills as suburban mother's little helper. So prescription drugs have long created an exclusive space in private clinics for white middle-class narcotic consumption. And the way that they've been framed as medications as opposed to drugs has pharmaceutically enhanced the whiteness of people whose privilege would otherwise be in question because of a stigmatizing diagnosis like addiction. And then very quickly, I've been spending a lot of time on the divergent racial identities of methadone and buprenorphine, the history of which is something that actually led me to collaborate with Sam Roberts. So this is a really nice reunion, this panel. But we have to remember that methadone was introduced as Nixon's first weapon in the war on drugs, in the midst of race riots and white flight from the cities. And nightly news highlighting heroin as a Black problem and a problem of crime rather than health. So in the current moment, there's a big contrast between methadone and buprenorphine, both of which are opioids in the same drug class, pharmaceutically very similar, but completely different racial symbolism attached to them and completely different regulatory requirements. And the image of who is not only an opioid, somebody with quote unquote opioid use disorder, but also a buprenorphine patient is totally different than the image of who is a methadone patient, quite deliberately so. This is something that's been very carefully crafted. So I'll leave it there, and hopefully I've left some time for our discussion.
That's great. That's great. Well, let's get right into it. And especially, I thought I heard, unless I don't think I was delusional, but if at one point we could talk about this whole issue of color blindness as like a minimization of racism in terms of the approach to this. I think we've all heard that, but let's get right into the history. And I want to pose this question too. Can you sort of walk us through the moments in history of the war on drugs where it became embedded into treatment? You know, we've been taking, Sam did as well as Helena did a great job of bringing us from actually going back right after enslavement ended and alcohol and to this present moment. But could you sort of take us through some of those moments in history that stand out with racism being embedded?
You mentioned both. You mentioned me and Helena. Which one did you want us? Which
Sam,
one did you want to go
I'm gonna
first,
nominate
Joe?
you. I'm going to nominate you only
volunteered,
because
right.
Yeah,
I think you
that's
have
real slick. That's real slick, Helena. That's real.
Well,
for chronology's sake, right?
Yeah, right.
A
Chronology's
little bit
sake. Yeah.
earlier.
yeah, slickness is a whole different behavioral thing.
I was
I'll
slow
tell you
on the
about that
draw.
later.
I was slow on the draw.
All right.
I'll say that. I mean, it's a question I think that a lot of us are trying to grapple with at this moment. I would say, just for framing comments, we have to really think about what is, if we say for the last nearly about a century or more, really have put up a dichotomy between drug use is a vice, it's deviant, it's immoral, etc., or problematic drug use is a disease. And these are pitiable patients, right? Between criminalization and medicalization. We really need to be, I would say, certainly skeptical of the first, of criminalization, but we also need to be careful about medicalizing drug use as well, because our communities have been on the negative side of both of those professional communities. I think, anybody just who's vaguely aware of the history of either the war on drugs or the history of medicine can name at least a couple of examples on either side where Black people have gotten, communities of color have gotten short shrift. So that's one thing. And I would say another thing is that we need to really think about, this is what I meant by saying seizing the means of treatment, which wasn't to say literally all treatment needs to be run by people of color. I mean, God, wouldn't that be a beautiful thing? But, that's not what I'm arguing. What I'm saying is that there needs to be a very conscientious and deliberate and thoughtful incorporation of not just mental health needs, but also community needs, and also the political subjectivity and needs of these communities. And so that that means that how we define, what we used to call rehabilitation, what today we, more likely to call recovery, those definitions need to be uncoupled from our other thornier history of race. So if you look at, let's just say like the history of methadone, for example, which, we've known for, years now is a staple of doing good harm reduction when it's used in the right manner, and doing good recovery. But in the wrong manner, it's often used as a way of creating disciplined subjects in manners that fall most heavily on us, meaning the definition of rehabilitation means, have you gotten a job? Well, then the question is, well, what kind of jobs are available at any given point in time, which, as we know in our communities, quite often they haven't been. I think earlier somebody mentioned white flight. I typically don't call it white flight, I call it capital flight. The problem wasn't that the white people left, the problem was that all the jobs and the investment left. We need to really think about how we define recovery in terms of criminal justice involvement. What does that mean if one lives in a community that's already hyper-policed and it's almost impossible not to have an engagement with law enforcement? So I would say that in terms of just framing that history, and certainly there are specific episodes, but I think the through line through all of that history has been drug policy as a means of disciplining Black bodies, be they newly freed citizens after the 13th, 14th, and 15th Amendment, people who were trying to claim their own labor, be they migrants from the South fleeing repressive regimes and trying to find self-determination and joy and freedom in the North, be they youth culture in the 1950s and 60s, or, a new type of politics asserting itself in the 70s and 80s, which the Reagan administration, found very convenient to discredit by the specter of welfare queens and also just, super predators who were, as Bill Clinton put it, hopped up on crack cocaine, et cetera. So I would say that's where we need to begin that. I don't see the war on drugs as being kind of a good policy gone bad, or something that was just too punitive. It really, I think, was start to finish constructed on the necessity of patrolling and controlling Black bodies, and not just in their jobs or in their communities, but also in the political sphere as well. And I really haven't even yet mentioned how the war on drugs has diminished Black political efficacy, either through voter disenfranchisement or the complete disparagement of alternatives to incarceration. I don't mean it like in the sense of drug courts, ATIs, but anything that could ensure public safety besides an officer with a gun and a baton and a court system and a prosecutor.
Thank you, Sam.
So I wonder if I could follow up on that. I think that's beautifully laid out. And where I pick up on the recent history has to do with the moment of the decade of the brain. So moving from the war on drugs to the decade of the brain, I think really highlights the false dichotomy that Sam laid out of crime and medicalization, because there's a lot that's left out from that analysis about what's actually driving many of the patterns that we see in the industries that we see. On the one hand, mass incarceration and increasingly privatized prisons. On the other hand, biotech and pharma, which are currently two of the largest economic drivers in the country, if not the globe. So these are incredibly powerful industries, and they draw on racial imagery just as much as all of our other industries. So a lot of what I've been doing in analyzing the quote unquote white opioid crisis has to do, as I mentioned, with racial capital. And I think that's the moment of the decade of the brain that came on the heels of the war on drugs as a political innovation. And maybe I will try to show some slides just because there are some images here that I think drive it home. Let me see if I can do it. Let's see, are you seeing my desktop now? Mm-hmm. Maybe, okay, so I'll start with this image. Not that one. All right, so this is the face of buprenorphine treatment. And my starting point for my current research was understanding this face of buprenorphine treatment in Bellevue Hospital, where I've worked for many, many years. The buprenorphine clinic that evolved there in the early 2000s was very exceptional. In Bellevue, the city's largest public hospital, largely patients of color, largely Medicaid or uninsured. The buprenorphine clinic, which met on Tuesdays in a corner of the primary care clinic, served primarily white clientele, many of whom were college educated, really, and it continues to look like that. Very exceptional group of people, and it's not an accident, So this is the face of buprenorphine from a website and an ad for buprenorphine. I'm not going to spend too much time on this, but this is my framework for technologies of whiteness coming from critical race theories, whiteness studies. The idea that whiteness is something to be understood and it's on its own, something that is an exclusive category, requires boundary maintenance, and much of that these days is done in the pharma and biotech sectors, actually. The fact that whiteness is the assumed norm and largely unspoken. Now, the Trump phenomenon since the last national election has gone along with more recognition of whiteness, more visibility of whiteness, but it's still true that in in news reports, if race is mentioned, it's generally a non-white person. If it's a white person in question, race is not mentioned.
It's not mentioned, right?
Yeah, and
And
then
Helen, yeah, and Helen, I think a great contrast to that previous slide of booth treatment to methadone treatment, you would have people standing out in the rain online in the Black community, not being trusted to take medication home for one day in the
so
middle of a pandemic. So that would be,
exactly.
yeah, a great contrast.
So here you have Mike, who is a real person, who's sitting in his diner. He's a business owner. He's a diner owner in Ohio. And you can see the American flags on the back of his diner wall. And he talks about coaching his son's baseball team and singing in the church choir after buprenorphine brought him back from a prescription opioid habit. So it's totally different reality. And then, you know, the fact that Black and white mutually interdependent and define each other. So I mentioned Mother's Little Helper and the protected white space of legal narcotics. That's always been there. That's not a new thing in the prescription opioid epidemic. And I like to emphasize, especially to my white colleagues, the fact that this whole system of racial capitalism is quite harmful to whites as well as non-whites. So, you know, we see the number of whites now dying off from overdose, but we also don't have to look further than COVID to see how incredibly poorly as a country we're faring compared to other countries, largely based on the fact that structural racism is not compatible with a public health infrastructure.
Right.
So the technologies of whiteness that I mentioned, so addiction neuroscience, this is the moment of the decade of the brain. And this is President Bush the first, prioritizing research on addiction and other mental health problems as brain diseases. And that is a moment where the idea of addiction as a brain disease really took off. And we're going to come back to this question, I think, in our discussion of language. That's something I think we're going to spend some time on as a panel. But my point here is that there's a lot of implicit racial coding in neuroscience having to do with redefining addiction as this universal, as a biological universal, but at the same time invoking an implicit white 70-kilogram male norm. And that's something that opened up the gates for a redefinition of addiction as well as vulnerability to opioid dependence. And this is an article about the landmark article redefining addiction literally in terms of language as a chronic medical illness.
Well, that's great. Just a bit of a time check because I want to, there are a couple of my issues that, but this was great.
So why don't I quickly walk through that new biotechnology development. Also, I contrasted buprenorphine, which was deliberately developed in response to what was perceived as a suburban prescription opioid problem, is very different than methadone, even though pharmacologically similar. And regulation, I think most of the audience may have heard of Data 2000, which legalized office-based buprenorphine, so that private doctors could, and this was a big breakthrough, that private doctors could prescribe it in the comfort of their offices, reversed 80 years of prohibition of private doctors maintaining opioid-dependent people on opioids. But the main point here is just that the congressional debates leading up to Data 2000 explicitly referenced the need for a new treatment approach that was not methadone for the suburban opioid problem, suburban youth that were caught up with opioids. And so it was a conscious decision on Congress's part to create this separate treatment track. And just to follow up, marketing and media. So some of the images that we've come to expect of the new face of addiction and the whitening of the image of heroin addiction after many decades of a Black and brown image of the heroin addict. And that linked to regulation of prescription opioids and the opening of heroin markets in the suburban and rural white communities that had been targeted by pharma. And then buprenorphine marketing, this is the website made by the manufacturer. And you can see the implicit racial coding here. It's loud and clear.
Yeah.
So I just wanted to give the audience a flavor for what these technologies of whiteness that have worked in concert to create what we now know as the white opioid crisis looked like when you break them down. And I'll leave it open to discussion about the role of capital, particularly racial capitalism, in this story.
Thank you so much. And Sheila, we'd love to hear from you on this question of the moments in history of the war on drugs and how it became embedded into treatment.
Well, I mean, I'd actually like to pick up on, Sam alluded to one form of alternatives to incarceration, and I'd kind of like to talk about the more traditional ones that we think about, coerced and mandated treatment, drug courts, involuntary commitment, and other kind of deals with the devil that have become increasingly common, I'd say, over the past 2.5 decades or so, as more and more communities experience the harms of criminalization and say, well, wait, hold on a second, this person was really engaging in this so-called criminal activity because they had an addiction, they had a disease, they were powerless, and is locking them up and throwing away the key going to be the solution, right? So this idea that we 2.5 years ago, or 2.5 decades ago rather, started already having conversations about, how do we divert some people who were swept up through criminalization into the treatment that they deserve, and how did those decisions take place, and in what ways were treatment facilities waiting there with open arms to have these a steady flow of clientele coming in. Time and time again, we know that treatment facilities have what we call high thresholds for engagement. What is a threshold for treatment engagement? It means typically, having active insurance, being able to show up for, scheduling an intake appointment, being able to show up for that intake appointment and produce a urine tox screen, sitting with a stranger, like someone like myself, when I was 23 years old, to basically spill your guts for an hour and a half, telling them everything about your drug use history until they can determine whether you have a substance use disorder and are deserving of care and what level of care you're entitled to. And then still between that, the call that you make, the intake that you do, the assessment, and then the determination that your insurance will pay for the treatment that's being recommended, and then the day that you start treatment, and being told from the moment, your last positive drug test was the one that you did on intake and during your assessment, but we don't want to see any more positive drug screens. And, a system like that isn't built for retention. It also doesn't very much use principles of attraction that harm reduction do to actually bring people in and are engaging. I mean, year after year, the National Survey on Drug Use and Health, which is an annual epidemiological study conducted by the Substance Abuse and Mental Health Services Administration, they find among people who perceived a need for treatment but didn't seek it, consistently the top 2 reasons, they're interchangeable. Year after year, the top reason being I wasn't ready to stop using, and the other one being I couldn't afford it, as being reasons that people don't seek treatment. And so it's convenient to me how alternatives to incarceration and people's dissatisfaction with criminalization emerged during a time when treatment facilities were also having a real PR problem and continue to have a PR problem in getting people to voluntarily come and then want to stay and play by the rules. And, the ways in which, we as treatment providers were complicit in these systems that could guarantee ongoing clientele and ongoing referral sources. And, I think about this a lot as a social worker who, ethically is, a mandated reporter. I'm, supposed to report when I see certain things, particularly around substance use or child and parent neglect and things like that. But, I think about how oftentimes professions like my own have been complicit in thinking that, the ends justify the means. So as long as this person got the help that they needed, maybe this is what they needed to get in, right? Like rather than, using principles of the carrot, we've often, like in the field of treatment, become beholden to the stick, and we've become complicit in the criminalization of drug use because it does guarantee that people will come, people will show up, that people will have to pay for treatment, otherwise they go back to jail. And oftentimes they end up being in treatment and being in and out of treatment for much longer than they would if they had served the time to begin with. And, I think that these are really important conversations for us to have in terms of, you know, really as a provider, looking at our attendance and looking at our, you know, our client list, who comes into treatment, who are their referral sources, and what are the racial and ethnic demographics of these communities that are coming in? And, you know, what are the average reasons for treatment termination among different ethnic and racial groups? And are referral sources part of that conversation? And do we know that POs are more likely to, you know, to violate someone who's a person of color, particularly a Black person who we say produced a positive drug test, versus perhaps violating someone who was white, suburban, and, you know, had a very different kind of, you know, had a different way of being perceived. You know, we see this also in methadone and buprenorphine treatment, the punitive ways that drug testing and routine drug screening is often used very differentially. And some people are given chance and chance and chance again to stay engaged. And some people see their doses change. Some people see themselves getting cut off of treatment. And how are we as treatment providers, you know, with our own implicit or explicit bias, feeding into, you know, exacerbating these harms? I guess that's just a thing that I think about.
And you know, you struck a great point, even in terms of the treatment planning, in terms of differences between Blacks and whites. And I'd mentioned before this myth of color blindness, that there's a prevalence to decouple individual recovery from community trauma. You know, that it's sort of siloed, that there is no connection between my recovery extending into a community, and that's separated, or Blacks coming into treatment where there may be criminal justice involvement, but a treatment plan has not attenuated itself to dealing with that. So we're looking forward to having a specific webinar on dealing with treatment itself. But I want to advise everyone as well that we're going to have a question and answer period, and for the attendees to put the questions into the Q&A box. I took a sneak peek at some of the questions, and they look very interesting. But I think I may want to combine.
Can I hop in for just a second?
Okay, what I'm going to do, Helena, is I'm going to combine the next one, the next two questions, so we can save some time for questions and answers. But go right ahead, Helena.
Oh, this is just to tag on to what I think is the discussion right now, which is this separation between criminalization and medicalization, which leaves out a whole universe of community and institutional forces.
Right,
And
trauma,
and trauma, including trauma.
Right.
And that's deliberate. If the driving motivation for interventions around addiction is either control of Black bodies or making money in a racially capitalized society, then you're deliberately going to leave that out. You're going to individualize. You're going to blame things either on biology or behavior, and you're going to come up with individual marketed interventions. In the case of the medical moment, these are patented products that can be charged based on individual consumption. You're going to deliberately exclude everything else. And that's where harm reduction movements have played such an important role.
Absolutely.
Because they have been on the ground, grassroots, bringing the community back into view. Right. And so I'm hoping we can continue that conversation.
And we will, I mean, because, I mean, that is the situation, but yet there are lights and sparks of hope. I mean, there are harm reduction treatment, drug treatment programs where the philosophy, the opposite of addiction is not abstinence, it's connection. It's connection to community, connection to purpose, you know, connection, you know, to playing a part in my health, my family's health, and my community's health. So Sam,
Joe, I was going to interrupt you briefly just to say, you say there are harm reduction treatment programs as though you're not the executive director of one of the best ones in the country.
Well,
so I mean, just credit where credit's due. I mean, if we are, and in all seriousness, if we are aware of that as a possibility, it is largely because of your work and your work at Exponents. So
well, you know, Helena mentioned, I'll get into the others, but many of these, I mean, Alexis is doing great work with Truth Farm, upstate. And many of us have histories of looking at how the gay community dealt with the HIV/AIDS crisis. You know, what they did is that they organized. They didn't tell people to stop having sex. You know, they advised that there's a safer way to do that. Let's reduce the harm. They mobilized and they advocated and they gave people a sense of purpose and belonging to a cause. And, you know, it just like we had planned, but we went right into it. I mean, just this weekend, and we looked at two souls, two warriors, John Lewis and C.T. Vivian, that, you know, organized that, and that we can see a direct connection from, you know, Selma to harm reduction philosophy of social justice and organizing and empowering the individuals. So, but that's enough from me. I'm not this, but I
agree. And I also want to emphasize Black and Brown AIDS activism from the get-go.
Yes.
So white
Absolutely.
gay communities, definitely, they brought in a lot of their resources, a lot of their power, but Black and Brown activists were at the forefront from the beginning.
Absolutely.
The very strategies that you're pointing out.
Right, and the early days of bleach kits in the South Bronx, you know, but that is great. I think, and that brings us into how does language really fuel stigma, the drug war, and racism. You know, some of it is grounded in some of the historical notions that you've pointed out. It carries through to today, but I'd love to hear from you. How does language itself, clean, dirty, addict, drug user, relapse, recovery, all these have different messages that are going out. So please, if anyone wants to weigh into that, go right ahead.
If I could just, you know, also tagging from the previous topic and moving into this one, there's also, with the historical example of HIV activism, there's also, we have to be aware and vigilant against, in harm reduction, the threat of the deliberate ignorance of Black harm reduction or harm reduction in communities of color, and also of the co-optation of some of its most radical, you know, and critical points of view in the service of a biomedical corporate model. And we're already seeing that. You know, 15 years ago, you probably couldn't have found a course on harm reduction in any public health school, or they would have been quite rare. And now they're happening. And we're already seeing instances where, you know, people have been doing the work for a long time because they don't have the credentials of a master's degree, you know, find themselves actually in some of the same places where they've always been. And so we have to be very careful about that moving forward, because that's something we kind of want to hold up, that other history of activism, without acknowledging that, you know, within it, there were some tensions. I mean, there were Black gay activists, or just, you know, Black gay men and women who, you know, often felt alienated from that activism as it was becoming, you know, as it was attracting a lot of the attention and a lot of the funding dollars. And so, you know, people who had to either try to work within those systems or work outside of them. So, I mean, like, good histories of that. I have a good colleague, Kevin Mumford, who's written about that. Stephen Thrasher is another good person who's talked about some of that history. Kathy Cohen is another as well. So I would say that's something that we should also talk about, if not in the remaining time we have here, but also moving forward.
Absolutely.
So on the other end of language, but also going back to harm reduction activists among Black and Brown, I just came from a panel at National Academies of Medicine with two very powerful Black women coming out of a harm reduction tradition, who explained that not only the opioid crisis, but opioid use disorder as a focus right now for federal policy in itself is a dog whistle to whiteness and who is deserving of attention. And they argued powerfully for us not to use the term opioid use disorder as we're talking about overdose,
Right.
but rather talk about, rather than opioid overdose, to talk about overdose, period. And if we actually look at who's dying of overdose right now and from what, it's true that opioids of different kinds are woven throughout, but stimulants have an increasingly large role as well. And we're overlooking a lot when we focus on opioids. So I just thought, you know, that's an interesting take too, that
Absolutely.
opioid overdose in itself is a heavily racialized term.
Absolutely. Just like ignoring meth as an issue in some communities, just totally has totally succumbed to the attention on opioid use disorder, which is a far cry from when folks were called dope fiends. So absolutely. Sheila, do you want to comment on that as well, or?
Yeah, no, I really appreciate that Helena kind of brought that up, because I think it is really interesting that people are still holding on to this framing of it being an opioid crisis and pinning it on the use of a certain class of substance without really any sort of clarification in really acknowledging the role that polysubstance use, using more than one drug, has been playing in this crisis. But that, you know, it's not the use of these substances alone that's the problem. People can use these drugs safely in ways that are medically useful and in ways that are helpful and improve quality of life. And that even dependence on these substances for pain relief, ongoing chronic management of some conditions is actually quite okay. It's almost created this reverse, like, also opioid phobia. And during a time when we have to both grapple with this increased fear of restricting access to these illicit prescription substances, when we know that we've had an opioid crisis in Black and brown communities for a while, and it's not a crisis of overuse or overaccess, it's been the exact opposite. And I think one of the dangers of framing this as an opioid crisis and people still holding on to the relics of blaming big pharma and blaming pharmaceuticals for this is that we've swung the pendulum the other way. And I think what happens a lot is when we flag certain issues, first of all, between the time on the ground when people are dying and people are actually seeing headlines and people are actually passing policies, years can pass. But when those years pass, the pendulum swings so far that we end up taking these really harsh efforts. And also we end up feeding into the wrong narratives. Again and again, we have to remember that the vast majority of even people who develop their problems with prescription opioids, they weren't necessarily the first drugs that they'd ever used to change how they felt. Most people who, who developed opioid problems with legal pharmaceuticals either had tried other drugs before and were perhaps starting to use their own prescription stripes a little bit more, but even that number was very small. And a lot of them were actually folks who were getting these pharmaceuticals from other folks, right? They were getting it from friends or family members, and often for free. And so we also have fed into this mythology that these demon drugs hijack these folks' brains, and that if not for the drugs, they wouldn't have developed these addictions, but that also it was the drug that was the problem. And in still sticking to that opioid framing, we take out the nuance of the role that the illicit market and illicit manufactured heroin and fentanyl have played, but also that, stimulants have been part of this equation for a while, and that there are parts of this country where methamphetamine involved overdose deaths have been the leading cause of drug involved deaths for years. And, there's a lot of parts of the country, particularly on the West Coast, where stimulant involved deaths continue to be on the rise, but really, overdose has always been the problem. And I think that when we pin it on any drug, what happens is we pin all our solutions to those substances. And again, we end up chasing demon drug after demon drug. And right now it's fentanyl. DPA, the organization that I work for, we've been pushing back against permanent scheduling of fentanyl and all of its analogs for the simple fact that we know that when you keep criminalizing and, playing whack-a-mole with the new drug and criminalizing it and penalizing it, we just see new ones emerge, right? And we now are starting to see, I cannot pronounce this drug for the life of me, isopetamazine as this new synthetic opioid that's emerging, and we have to acknowledge where fentanyl hysteria brought us to this new drug emerging on the market, but that for a lot of us, we weren't paying attention to cocaine and methamphetamine, and we tend to have this one drug focus as well, and this overly simplistic narrative. And I think the other thing that, looking at the 2019 data and like the way in which stimulant-involved overdose deaths continue to increase at really, really rapid rates, is that now we gotta zoom out from the drugs. We gotta look at social determinants of health. We gotta look at structural factors.
Yes.
We gotta look at the housing crisis that we're in. We have to look at economic inequality. We have to look at systemic racism and medicalized racism, and the ways in which, all of this is coming to light as the overdose crisis only intensifies, and as we see COVID as well.
Right.
I'm gonna stop
you
there.
said so much. You said so much. I'm getting time signs and texts from area, and we have some great questions. But especially, Sheila, when you talked about really the disparity in looking at what I call, well, some folks have called accidental addiction, the treatment from, those that have had a route of prescription drugs, as opposed to those with that found their way there through illicit drugs, in terms of language and stigma and difference and sympathy and compassion. And you talked about the rise of overdoses. Some of the data states that it's up 42%, 42%, especially in the middle of this pandemic. And I think many of us fear that when the overdoses in the faces of those that are victims of overdose deaths come from city projects and they look like me, that the compassion will go away, the money will go away, the tension will go away. So anyway, I want to go, this is such a great discussion that I also want to give voice to the 208 people that are with us. And I just have a couple of questions that I want to bring up from the Q&A queue. And that is from Angela. And I'll just get one answer from this, a condensed answer, because we're running a little late. Angela asks, what role do you think DEA, hey, good old DEA, plays in the racialization in treatment for substance use disorder? Helena, you laughed, so I guess that's you.
Yeah, I would have mentioned the DEA many times had I gone through the technologies of whiteness in more detail. Just a couple of highlights is many of the bargains around restricting buprenorphine, making sure that only there's an optional certification process for prescribers, an 8-hour training course that is necessary in order to prescribe. And then once you prescribe, you get an X waiver. The DEA monitors your prescribing patterns. That was a bargain struck with the manufacturers and other regulators that really implicitly was to keep it restricted to white middle-class markets. And it got the result that was intended. Right. That's one reason that buprenorphine is now in the private sector. White middle-class consumers, it's an exclusive but highly lucrative market. And that was a deal that was struck to get it out to quote unquote safer clientele. And then of course, methadone programs still are heavily DEA regulated. And from their inception, the DEA wasn't even called the DEA when methadone maintenance clinics were first rolled out. But the idea was the same. It was to partially criminalize the so-called treatment.
Absolutely.
And separate it away from other kinds of clinical care.
Right. And they're not exercising no-knock warrants against doctors in their offices and throwing Black people in jail. Another question, which is a great one because we have a number of providers. And this is from Joan, who's a CASAC. And she asks, how can a CASAC balance triggering behaviors of active substance users and supporting a harm reduction approach at outpatient programs? Wow, I wish I was on the panel because we have a harm reduction drug treatment program. But please, any thoughts on that, folks? I think a harm reduction drug treatment program, and we have CASACs there as well, it focuses on any positive change. I mean, we realize that, you know, recovery is not determined by a positive toxicology. Language is very important. We believe that folks are entitled to a self-directed approach to their treatment. There's a number of things that we do. But I'll throw it open to the panel. Any suggestions for Joan?
Yeah, I can talk a little bit about that. I mean, I think that the responsibility of providers is to really create systems and structures. If you are going to welcome in folks in different stages of change, I think you need to build in structures so that people can self-select into mixed groups or groups where people have like-minded goals. And I think part of that especially is just to acknowledge that, you know, I think all providers, we should all have menus of options when it comes to treatment, right? You know, I think that we should have, you know, we should have harm reduction groups for folks who are interested and willing and want to engage in talking about how they're managing and how they're living. We can have, you know, groups framed as like recovery readiness groups for folks who are kind of maybe thinking of exploring making changes. And then, you know, having different kinds of, you know, recovery-based groups or abstinence-based groups for folks to opt in. But then, you know, really it's the role of the facilitator and the group in these kinds of mixed groups to really hold space for and to set the tone and to set standards for where, you know, what is allowed and what isn't allowed, you know, how to take care of yourself if you are if you are managing being triggered in group. What are some strategies that you can take while being here? You know, do you need to step out for a moment? How can you talk to this person about what's going on for you? Using individual sessions also, I think as a supplement is really important. But I think, you know, treatment facilities need to, it's a lot of work to create inclusive spaces. Yeah. And I think you have to let people self-select, but then there's a lot of onus on, you know, giving power to the moderator and then really empowering the group to kind of set their own tone and their own expectations and like letting people know what their limits are. And I think that's okay. I don't think there's anything about a harm reduction approach that says you have to be, you know, if you're uncomfortable, you're uncomfortable. And I think, you know, helping people to take care of themselves and hold that, I think is really important. Helena.
Those are the words of a very well-trained therapist. And
my mentor is on the line. Shout out to Andrew Tatarsky.
But I also want to kind of turn it back to the question of structural racism and the warning that I believe it was Sam gave about what's lost in the ethos of harm reduction when biomedical spaces try to take it on. So much of harm reduction has to do with also who's doing the providing, quote unquote. Right. Right. And what kind of understanding of the lived reality of the person they're working with do they have? Right. Because for a provider who shares a lot of that lived reality, it hopefully is a shorter step to understand the principle that Joe laid out of you meet people where they are and you see things as a positive that the outside observer who may be from a different class and race background would not understand as a positive. Absolutely. You have to have a deeper appreciation for the structural circumstances that the person is working in and from whence they came. And so that's one thing I deeply appreciate about a lot of the really vibrant harm reduction organizations is that they employ and train people from the communities that they're serving. And so they can bring that lived experience to bear in recognizing the positives.
Right. Lived experience is vital to engagement. And that's what we found out, as well as throughout the country. And people with lived experience at leadership positions as well, not just in the field, not just, you know, at sites. And I hate that expression, in the field. You know, Oasis has, I know I'm going to get in trouble, but I don't care. They have what they call field offices. I mean, that even language in that strikes an imbalance of what's going on in the field and what's going on in the big house. So, yeah, I said another one.
I'd also like to. Oh. Sam, do you want to?
Well, I was just going to say that, you know, this is also replicated, that this isn't entirely new, and that this was also the debate with, you know, those of us in the audience who might remember or have read of the Great Society programs and the War on Poverty programs, which initially had in their language, just kind of offhanded language, maximum feasible participation. And I don't think the Lyndon Baines Johnson administration knew what they were getting themselves into when they had that in there, because communities all over the country said, oh, this is our moment to get involved in all of these agencies, which historically have been there to quote unquote serve us, but never actually let us participate in that endeavor. And I think that's really important, because in a lot of ways, as you were saying about language, what we call a field office and what language is stigmatizing, it's really interesting that we think of people with trained credentials as being intellectuals, but people who have this experience and those of us, everyone on this panel has worked with harm reductionists for, a long time, know that, the people who have been doing this work are some of the smartest people you'll ever meet in terms of their political analysis and how they see the world. And then we make these divisions between people who work in the field versus people who quote unquote think. And it does a lot of detriment to the movement itself.
I also want to just talk a little bit more also just about how we as potential administrators, colleagues, supervisors, directors need to really think about our obligations to staff with lived experience, whether they are credentialed or not, are deemed as peers, or are seen as recovery coaches, or are, in various levels of credentialing, because we know that, like, for instance, as a social worker, you're supposed to get a certain amount of clinical supervision that's required as part of your licensing and credentialing, and certain other professions is expected. And I think, as substance use treatment as a field does start to bring more folks with lived experience, including those non-credentialed folks, that we need to really talk about fair wages for these folks who are doing a lot of emotional labor in these kinds of settings, and oftentimes going back home to the same environments in which they are living out these realities as well. And the ways in which they deserve and require, adequate supervision and guidance and opportunities for professional development and leadership, helping them navigate transference and countertransference and their own boundaries, how they go home, how they take care of themselves. Because the other thing is that harm reduction more broadly and a variety of fields where people, that line between work and life is blurred or doesn't exist, is that we perpetuate myths of like the martyr, but also like the impervious forever helper who has a somehow unlimited capacity for giving and caring and tending, often to the detriment to themselves. And we've seen in our own movement in harm reduction how many lives we've lost in the midst of this overdose crisis, our own leaders who have lost their lives to overdose, who've lost their lives to a variety of other health conditions that were left untreated or otherwise not taken care of because of the work. And so I think another thing that's really important and a lesson that we should learn from our past is, like, how do we take care of ourselves and each other, and how do we compensate each other? How do we guide each other? How do we give each other second chances? How do we give each other space? And how do we create, supervisory and management and leadership structures that also are harm reduction oriented and don't produce harm in our staff, but only expect them to reduce harm in clients when we might actually be creating harmful conditions or exploitative conditions for folks with lived experience who are working in these settings.
I was saying, Sheila, those are powerful issues, and those issues will take us into the future. And especially we see how the impact of COVID-19 has affected the delivery of services. Within the fact that, the Black community was specifically felt the brunt of this, disproportionately felt the brunt of this pandemic, as well as the double pandemic of overdoses as well. I mean, speaks to and expose the inadequacy of the healthcare system, the criminal justice system. And I think harm reduction in its holistic approach takes it out of the individual silo to say that my health is dependent on my community's health. Which brings us to a great question that I don't have an answer to, but I know the panel may. The question is, in what ways do you see the emerging field of prevention science meshing or conflicting with work in harm reduction? Wow.
Probably along the lines of what
Please,
you
no,
just
no,
mentioned, Joe.
Helena, yeah, please go. Please go, please go.
I was just going to say, it's exactly what you talked about, Joe.
Yeah.
The holistic approach. The
Mhm.
harm reduction organizations are among the only ones that are asking, how can the community's economy be revitalized? What kinds of policies are holding us back? That's these things are intimately linked. If we address root causes, we're going to hit prevention and we're going to hit harm reduction.
Absolutely. Absolutely.
Go ahead.
I have one last question, and that is, because they're coming in quick and in a hurry, how can we think critically about differences in drug use and drug treatment across communities of color, while not decentering how white supremacy structures those differences? I'm going to repeat that. How can we think critically about differences in drug use and drug treatment across communities of color, while not decentering how white supremacy structures these differences? Well put, and I believe we mentioned some of the disparities in buprenorphine and methadone, which is a clear difference in treatment across communities, and reflective of white supremacy. But does anyone want to add any light to that question?
I wonder if or any panelists can kind of infer why it's important to distinguish among communities of color in terms of type of drug use or pet.
Actually, I think they're saying across communities of color, while not decentering, but
like differences in rates of use, or differences in, I thought the question said differences in drugs. Drugs being used, or different rates of just general.
Yeah, you're right, Sam. How can we think critically about differences in drug use and drug treatment across communities of color? So I think you're on the right track, Sam. Well, okay. Well,
so I can take one stab at that. The reason I was asking about the rationale for the question is that there is, of course, a long history of dividing different groups, trying to distinguish them based on, right now I'm thinking about Asians. Asians are the model minority myth, right? They're constantly held up as the group with the lowest substance use rates and whatnot. If you take a closer look, you'll see that actually substance use tracks pretty closely with how oppressed a particular Asian subgroup is, what their socioeconomic circumstances are, but we'll leave that to the side.
Right.
So, I mean, there's a danger and a preoccupation with, well, what are the differences? What explains them? That being said, I'm going to take, for example, First Nations communities, which have been extremely heavily affected and from the get-go had much higher rates of opioid overdose than white communities, right? And I think that the very analysis we've been threading throughout this whole conversation would be we would have to bring it to bear with them. Right. What explains that? And there are just so many different historical structural oppressions that explain that, including deliberate introduction of certain substances to those communities to oppress them. I can't even begin to list them all. So that might be one of the few instances, like if it aids us in an analysis of structural racism, fine. But if it divides us around questions about like who's more of a model than others, then we're going to fall into the same trap.
Right. And it struck me too. We have 5 minutes left, but I just wanted to say just how the deliberate introduction, at least I can remember in my age group, how the influx of heroin, the Black community, and the dismantling of the civil rights movement and the human rights movement, and just shotguns fired from every side, from Vietnam, from heroin, and and the results from that. But I want to say that there are a couple of things. I want to thank our panelists. I also want to bring attention to the attendees that we have. At the bottom of your screen, there's a polling icon where the Harm Reduction Association, we want to look at some of your responses of what upcoming topics you would like to discuss. And then what I'd like to do is just before we end, I would love to just have a, and I'm going to ask Sid to bring this up, just a minute of silence for celebrating the life of John Lewis.
Joe, I'm gonna wait 1 second while people fill out the poll.
Okay.
And CT Vivian as well. Can we?
And yes, and as well as CT Vivian as well. And because they took the blows on that bridge in Selma that we're standing on their shoulders. And I do see a direct connection from that struggle for social justice to what we're seeing today. You know, folks on the street, you know, asking for the same thing, you know, with even more vicious resistance, but they gave their lives for it. And so I'm going to ask folks to fill out the poll. And if you could, Sid, just pull up that slide that we did for John Lewis, if you could do that. And if we could just have a moment of silence. Rest in power. Thank you so much. Sid, if you could just show the last slide, I just want to encourage all of us as I thank Dr. Helena Hansen, Dr. Samuel Roberts, and Dr. Sheila Vakharia for their participation and passion, heart, and spirit to bring this discussion alive. You know, we really just scratched the surface of this, and we want to continue. I encourage all of us, all the attendees, to tune in next week, where we are going to have a town hall discussion on criminal justice, race, and drug treatment with a dynamic panel of Cassandra Frederick from DPA, Deborah Reed, Legal Action Center, Tracy Gardner, Legal Action Center, yeah. Dinah
This is
Ortiz,
a great panel.
Right, Dinah Ortiz, who is a child welfare expert, and moderated by the co-chair. If you could just bring that back for a second. Said that session will be moderated by Alexis Plus, who is the co-chair of the New York State Harm Reduction Association, my comrade, and also executive director and founder of Truth Farm. We have a number of people registered, and I'm looking forward to it as well. So, hey, on behalf of everyone, the panelists, the association, I want to thank folks for just taking time out in the middle of the evening to help us lift up these messages of hope and struggle and advocacy and just a better tomorrow. So I thank you. Good night.
Thank you, Joe.
All right.
Thank you, Joe.
Oh, thank you.
Thank you.
Guys. All right. And we will see you next week. Thank you, and bye-bye.